All right, so thank you to Dr. Anderson for a nice introduction, and thank you for having me here today. So I'm going to talk about fetal alcohol syndrome today. I've never given a Zoom talk. It's kind of weird talking to a essentially empty room. But I was just thinking this may be a good thing because anytime I tell a joke, I can just assume you guys are all laughing hysterically instead of me just sitting here watching nobody laugh. I'll just introduce myself again briefly. My name's Ken. I'm a second-year family medicine resident. I'm at the Center for Family Medicine here in Sioux Falls. I went to a medical school in Charleston, South Carolina, at the Medical University of South Carolina. I have a particular interest in the maternal substance use disorder, which is why I put this talk together here today. These are my kids. This is my son, JD. He's 4. He gets his sense of fashion from me. This is my daughter, Ruby. She's 6. She's in a leopard print shirt, tights, shoes, and leopards on her skirt. And this is my wife, Katie. So disclosures, I have no disclosures to report to you guys today. So the objectives for my talk today, the first thing I am trying to do is tell you about the history of prenatal alcohol use and what people have been saying about it kind of throughout history. Then I'll talk a little bit about the diagnosis of fetal alcohol syndrome in addition to the prevalence of this disease. And then the last thing, I'll just sum up with some of my thoughts on the intersection of family medicine and fetal alcohol syndrome and why I think this is important to family medicine. So I'll start with the history. So it's kind of a lot of conversation about when exactly people first started talking about prenatal alcohol use. My guess is people started talking about it as soon as people start drinking alcohol. But in the literature, the time when it kind of starts to pop up more is in the mid-1700s in England during what's called the London gin epidemic. Around this time, France and England were having some fights. King William, who was in charge in England, placed a ban on French wine imports. At the same time, there was a lot of wheat production going on in England. Gin is made from wheat. So instead of drinking French wine, the people in England started making a lot of gin, and this led to what was called the gin epidemic. Around this time, a lot of social commentators started to discuss the use of alcohol, especially the use of gin, by the working and lower class people and how this was ruining society. This is one such social commentary. This is a painting called Gin Lane. This you can see front and center here, a picture of a woman who perhaps was breastfeeding, neglecting her child who's falling. Over here to the right, you see a picture of a woman feeding, looks like almost giving a shot to her child. And then in the back here, you see a woman being put in a grave with the child here left to fend for himself, really trying to represent some of the harms that prenatal alcohol was having on kiddos. Move forward here and go across the pond to America, talk about this American physician, Benjamin Rush. So fun facts about him, he was one of the signers of the Declaration of Independence. And he's also considered one of the founders of modern psychiatry and one of the people who really connected biology to brain disorders. And in 1805, he came out with this publication where he was really arguing for the medical concept of addiction and the idea of addiction as a disease. And what he was seeing in his patients was really this shift from people drinking alcohol because they like to drink alcohol to this sensation that people drink alcohol because they had to, and having this compulsion to drink even though they didn't want to drink and even though they could see that it was ruining their lives. And it was really this loss of control that he described as the disease portion of addiction. And around this time, this was kind of a time around temperance when people were trying to get people to stop drinking alcohol. And this was this idea that Benjamin Rush was promoting, this medical concept of addiction. This was something that the temperance movement kind of latched onto because they, now that they understood that alcohol could cause disease, they had this idea that we needed to stop drinking alcohol because it was going to cause this disease of addiction in everyone who was drinking. Moving forward to Austria, we have a psychiatrist named Benedict Morel. He was a director of a mental asylum in France, where he was seeing a lot of people who are having trouble in society. And he became interested in this idea of how people ended up in his mental asylum, and he referred to these people as degenerates. Quick side note, what is a degenerate? When I heard the term, it sounded controversial and sounded kind of interesting, so I looked into it a little bit. And what I found is that degenerates are a pathological deviation from what's considered to be the perfect human being. And some of you might be surprised. I was certainly surprised to learn that the perfect human being is not my wife. I heard that she has some flaws, but I'm not aware of those. Benedict Morel, so his theory, which he developed in the 1850s, was that what he was seeing in his patients in the asylum was that a lot of the patients had a history of alcohol abuse in their family. And what his hypothesis was that alcohol abuse in one generation would leave lasting biological effects on the subsequent generation, predisposing them to things like intellectual disability, immorality, and eventually physical deformations, including sterility. And policymakers in this time kind of latched onto this theory as a way to say we don't need to help these people because they're eventually will become sterile, and these family lines will die out. This theory, among other things, eventually led to Nazi eugenics. To go back to the history, so we move forward again a little more, 1899. At this time, a British psychiatrist named W.C. Sullivan published this paper. It was kind of the first academic publication that rigorously studied the effects of alcohol in pregnancy. He was a medical director at prisons, and he studied his prison population comparing infant mortality for offsprings of both alcoholic and non-alcoholic mothers. And one of the things that's impressive about this study is that, even, what was this, 200 years ago, he was thinking about things like matching populations. So he took alcoholic patients from the prison and compared them to non-alcoholic patients who were also in the prison. Should be, more or less well-matched, at least as far as socioeconomic status and things like that. And this is some of the data from the paper. On the first column is alcoholics, patients who live, 56, patients who died, 69, for a mortality of 55%. Over half the babies of the alcoholic mothers had died. And this is in comparison to not alcoholic mothers. 105 lived, 33 died for 23%, suggesting an over twofold increase in the mortality of infants of alcoholic mothers. We move forward to 1919, when this was the time of Prohibition, and there was a suspicion that alcohol was leading to problems like the disintegration of family life, crime, things that potentially related to urbanization, but certainly potentially related to alcohol as well. Around this time, there was a lot of protests against this idea. This is a picture of a protest. If you look closely, you can see me in the back there. 14 years later, Prohibition was canceled. And really at this point, society had a really bitter taste of this temperance movement. And there's really this backlash against this idea that alcohol is dangerous. More and more people were promoting the idea that alcohol was safe, that alcohol does not cause addiction, that alcohol really does not cause any problems, partly because of this bitter taste they had from the Prohibition. And this bitter taste wasn't just something that was seen in popular culture, it was also seen in the scientific world. In 1942, about 10 years after Prohibition ended, this pair of psychiatric researchers, Dr. Haggard and Jelinek, came out with this book called Alcohol Explored, where they kind of described the most recent research findings in alcohol. And what they argued for in this book was that alcohol does not have any effects on the fetus and does not cause cirrhosis, which is a common liver complication of alcohol use. They also tried to argue that alcohol does not cause things like esophageal cancer and cardiomyopathy, which are all things we know that are related to alcohol today. 1960s, we have this U.S. Senator from Iowa, Harold Hughes. So this guy was kind of an interesting guy. He's a former alcoholic. He fought in World War II and came back with PTSD and tried to drown his sorrows in alcohol, and had this kind of clarifying moment when he was in the bath one night with a gun, thinking about killing himself. And he, for whatever reason, decided to commit his life to Jesus. He became an evangelical Christian and subsequently became governor and then U.S. Senator of Iowa. And one of the things he's best known for is that he developed the NIAAA. This is the National Institute on Alcohol Abuse and Alcoholism. And this was the first national health organization focused on alcohol and focused on the effects of alcohol and trying to put it into, try to contribute research money towards this problem. And Harold's goal was really to move the view of alcoholism from a moral deficiency to a disease. I think he had a hard time with this, both when he was an alcoholic and when he was kind of in the recovery phase. And this is kind of his passion in life. 1973, we have Dr. Jones and Dr. Smith, a pair of Seattle pediatricians. They came up with this paper. This is the first description of fetal alcohol syndrome, or the set of phenotypes that's associated with prenatal alcohol use. And what they reported, this is a figure from the paper, they reported facial dysmorphology in addition to neurodevelopmental disabilities and poor growth. Of note, a similar syndrome was reported out of France in 1968, a few years before. And after these papers came out, these were followed by subsequent case reports of other people reporting the effects of prenatal alcohol and seeing these abnormal faces and neurodevelopmental problems in kids. And so this is in 1973. And the government promptly acted the 1976, 3 years after the report of fetal alcohol syndrome. The FDA had tried to place this warning label on the alcoholic beverages saying that alcohol during pregnancy can have effects on the baby, but this was blocked by a lawsuit. The next year, the NIAAA, the National Institute of Alcohol Abuse and Alcoholism, they came out with the first government statement regarding alcohol use, and they came out and recommended max of 2 drinks per day. A few years later, the U.S. Surgeon General came out with a little more aggressive recommendation of 0 alcohol tolerance during pregnancy. 8 years later, so this is 13 years after the original attempt by the FDA to put these alcohol label or warning labels in alcoholic beverages, they finally passed a law to mandate these warning labels to be on alcoholic beverages. In 2002, there was some discussion by the fetal alcohol syndrome research world that by only focusing on fetal alcohol syndrome, which included the facial dysmorphology, the severe neurodevelopmental problems, the growth retardation, that perhaps we were only capturing the tip of the iceberg of negative effects of alcohol during pregnancy. And so they developed this umbrella diagnosis called fetal alcohol spectrum disorder, or FASD. And the goal of this diagnosis was really to start capturing some of the less severe phenotypes and patients that were exposed to fetal or prenatal alcohol, but maybe do not have the full fetal alcohol syndrome phenotype. And like I said, in America, we've had government recommendations to have no alcohol during pregnancy for the past 40 years. In other countries, this is still something that's controversial and debated. In 2015, in Britain, the Royal College of Obstetricians and Gynecologists, this is the equivalent of ACOG in England, they recommended no alcohol in the first trimester, but they did allow some light alcohol in the second and third trimester, suggesting that not all countries are as strict as America. And this is the last slide I have regarding the history of alcohol use. So this is just some data from the CDC. On the y-axis, I have a percentage of pregnant women who drink. On the x-axis, I have various time points. The black bars represent binge drinking. The gray bars represent just any alcohol drinking. And what you can see is that over time, over the past 30 years, the amount of alcohol consumption, any consumption, has ranged from roughly 8 to 12%. This was not necessarily a number that surprised me. I think, if anything, this number may be low. Of note, these data are developed by surveys, and it's possible that women were not inclined to admit to prenatal alcohol use and could have made these numbers lower than reality. But either way, roughly 10% of women drinking alcohol. And then what did surprise me is in the black bars, we have the amount of women who binge drink during pregnancy. 1991 to 2005, in this time period, this was defined as 5+ drinks in one occasion. In 2006 and on, this is defined as 4+ drinks. So the threshold of binge drinking was decreased, maybe explaining why you're seeing more binge drinking in the last 10 or 20 years. But it was quite surprising to me to know that 4% of women who endorse binge drinking. So that's what I have for this first part for the history of prenatal alcohol use. So now I'll move on here. I'll talk a little bit about the diagnosis of fetal alcohol syndrome in addition to the prevalence of this disease. So the first question is, what is fetal alcohol syndrome? Or what is fetal alcohol spectrum disorder? And fundamentally, this is a disease that's made up of 3 characteristics. So the first thing is prenatal alcohol exposure. This is something that's required for the diagnosis. This is coupled with a unique set of facial features, which is probably the only thing I remembered about fetal alcohol syndrome in medical school. I think we learned just that they had an abnormal face, but the specific details of the face include small palpebral fissures. So this is a medial to lateral border of the eye socket. They also have this smooth philtrum, which is really characteristic of the skin in between the nose and the mouth. This area is smooth instead of having a little bump there. And then the last thing is this thin upper lip. So the red upper half of the lip is thin compared to the lower lip. And I think, as you can imagine from just looking at these facial features, these facial features are very subtle. It's very hard to identify them and distinguish them from other facial abnormalities. The last thing is fetal alcohol syndrome associated with neurobehavioral dysfunctions. Most commonly, problems associated with attention, but can have a wide spread of phenotypical presentations. And so fetal alcohol syndrome, or FAS, is kind of the most severe version of the fetal alcohol spectrum disorder, decreasing in severity as you move to the right. And to qualify for this full fetal alcohol spectrum phenotype, you have to have the facial findings. You have to have the growth retardation as evidenced by weight less than the 10th percentile. You have to have poor brain development as evidenced by a head circumference less than the 10th percentile, in addition to neurobehavioral impairments. But like I was saying earlier, this diagnosis is really just the most severe fetal alcohol syndrome patients. And a lot of the less exposed patients kind of fall into these other diagnoses. The first one I'll tell you about is partial fetal alcohol syndrome, or PFAS. And this is a diagnosis where you need the prenatal alcohol exposure in addition to the facial dysmorphology and the neurobehavioral impairments. And here, what you don't necessarily need to have compared to the full syndrome is the growth impairment and the head circumference findings. But you still have the facial dysmorphology, still have the neurobehavioral abnormalities. And then we have the third diagnosis, ARND, or alcohol-related neurodevelopmental disorder. And this is something where you see prenatal alcohol exposure in addition to the neurobehavioral impairment. But importantly, you don't need the facial dysmorphology, which is a very tricky part of the diagnosis. You just need to have some prenatal alcohol exposure in addition to neurobehavioral problems. And then you have this fourth diagnosis. I didn't know exactly where to put it on the spectrum because it's not necessarily, doesn't necessarily have a clear spot. But this is ARBD, or alcohol-related birth defects. And in this case, you have both the prenatal alcohol exposure in addition to one or more major anatomical findings commonly associated with fetal alcohol syndrome, including congenital heart disease like ASDs and VSDs. Can also have things like horseshoe kidney, visual problems, hearing problems. And this is its own separate diagnosis here. But one question that comes a lot and is discussed often in the literature regarding the spectrum of fetal alcohol spectrum disorder is my next side note here. How much alcohol is enough to cause fetal alcohol syndrome? The short answer is that it's very controversial. The short answer is no one knows for sure. About 7 years ago, this economist named Emily Oster, she came out with this book called Expecting Better, where she took a deep dive into the data regarding pregnancy. And around this time, she had become pregnant, had a lot of people, her friends, family, giving her advice about pregnancy. She had her OB giving her advice about pregnancy. And as an economist, what she wanted to know is how much of the recommendations she was getting from people were actually data-driven. And she wrote this whole book about various data-driven findings in pregnancy. And one of the topics she looked into was drinking during pregnancy. And what she found based on her interpretation of the literature is that it's okay to drink a little bit while pregnant. And she got a lot of pushback for this, in part because really all the medical societies in America, the American Academy of Pediatrics, the American College of OBGYNs, Family Med, CDC, everyone across the board is recommending zero alcohol. And really, this is with the idea that because we don't really know how much alcohol is safe during pregnancy, in order to be safe, we should recommend patients to have zero alcohol. But if you look into the actual literature, my interpretation of the literature is that the research is really unclear. I think for binge drinking and the high amounts of prenatal alcohol consumption, it's clear and consistent across studies, consistent across time, that the binge drinking has bad effects on pediatric outcomes. But when you look at small amounts of drinking, and when I say small amounts of drinking, I'm talking about less than 1 drink per day. So like a glass of wine every other day, margarita every week, something like that. The research is really unclear, and there's not really a clear answer on how much effect that level of drinking has on pregnancy and fetal outcomes. And strangely enough, there are actually some studies that show a small benefit to small amounts of drinking. And in these studies and subsequent commentaries on these studies, there was this question raised: are we actually causing harm by not forcing pregnant women to have alcohol? Obviously, that's a crazy thing to say, and sounds very unreasonable. And the answer is I don't think so. But you know, it's something that has been discussed in the literature based on some of the data that's out there. So I'll show you one of the pieces of research I came across regarding low levels of alcohol consumption and fetal outcomes. So this was a study that was a longitudinal cohort study out in Detroit. And this was in 1998, so this was 25 years after the discovery of fetal alcohol syndrome. And by this point, it was well established through lots of different kinds of studies that alcohol has bad effects on kids. But the goal for them in this study was to determine the threshold, or to determine, to try to answer this question of how much alcohol is enough to cause this fetal alcohol spectrum disorder. And this is just one figure from the paper that just kind of summarized the finding from the paper. So on the y-axis, this is measure of neurocognitive development, in this case, processing speed. On the x-axis is amount of drinks during pregnancy in ounces of absolute alcohol per day. Roughly 0.5 ounces of alcohol per day are equivalent to 1 drink of alcohol. And what they found is that with no drinks during pregnancy, 0 to 1 drinks per day, 1 to 2 drinks per day, really you're not seeing much difference in this specific neurodevelopmental measure, and not much effect of alcohol on fetal outcomes. But then around 2 to 4 drinks, and especially 4+ drinks, you're seeing a prominent effect of fetal alcohol exposure. And one of the conclusions that they drew in this study was maybe somewhere around 1 to 2 drinks was around the threshold that they thought was enough alcohol to cause fetal alcohol spectrum disorder, or measurable changes in kids. And I think the question we have to ask ourselves as healthcare providers and as both as caretakers of children and also of moms, I think is to what extent are we basing our recommendations to pregnant women on data? I think we need to be aware of the recommendations we're giving, because we're really directing a pregnant woman's decision making. I think I do agree with all the AAP, AFP, all the recommendations they give, that we should recommend zero alcohol under this idea that we should be safe, because it is really unknown how much pregnancy alcohol is safe. At the same time, a pregnant woman is first and foremost a woman, and a pregnancy comes second. And I think we have to be conscious and respectful about how much we're going to dictate or recommend a pregnant woman to do or not do. And the second thing I'll say about this is that alcohol is legal. We're not talking about things like methamphetamines. We're not talking about heroin. We're not talking about marijuana. We're talking about something that you and I could go out and consume any day of the week, and it would be perfectly allowable. And we limit this during pregnancy, and I think we have to ask ourselves if this is really the right way to approach this. And I think when it comes to medical decision making, this is one question, but I think this comes to be a slightly more high stakes question when we talk about judicial issues and the law. So there was this case a few years ago in New York City where a pregnant woman went up to a bar, ordered a drink. The bartender refused that woman the drink of alcohol, saying that because she was pregnant, he or she didn't feel comfortable giving them alcohol. And the woman ended up suing the bar. She ended up winning, and the ruling was that the bartender, by refusing the woman alcohol, was limiting her freedom, and that was not allowed. And you can certainly see how this would be a hairy situation. Certainly, you can't always know who's pregnant, and obviously, you're not going to pregnancy test every woman who comes into a bar. I think the other problem here is that the biggest embryologic effects of alcohol on pregnancy may be during the first trimester, when it's probably the hardest to visually detect a pregnancy. And you can imagine this would become a very sticky issue. In addition to this, every state has their own policy on substance use during pregnancy. So in the first column here, I have the various states. I have South Dakota highlighted in yellow. And then whether or not substance use during pregnancy is considered A, child abuse, and B, grounds for civil commitment. So civil commitment would be an involuntary admission for inpatient psychiatric care. In the case of South Dakota, substance use during pregnancy is considered both to be child abuse, but also grounds for civil commitment. And the way they just describe a patient or a child that's been exposed to a substance use during pregnancy is here. And really the key term here is this abusive use of alcohol. And I think any lawyer would be hard pressed to argue that one drink a day or one drink every occasionally during pregnancy could be considered abusive use of alcohol. At the same time, I think by not putting a strict number or a strict definition on the amount of alcohol, I think they did leave the door open to perhaps use this law to say that women could not drink any alcohol during pregnancy. So just something to note. So to go back to the epidemiology and the prevalence of fetal alcohol spectrum disorder. So this is a paper released by Dr. May and his colleagues in 2018 called Prevalence of Fetal Alcohol Spectrum Disorder in 4 U.S. communities. I just want to give a shout out here to Dr. Amy Elliott. She's an epidemiologist who studies fetal alcohol syndrome here in Sioux Falls. I'm really impressed with the work she does. I hope she keeps up the good work. And I think really in reading this paper, what this made me think about was that understanding the prevalence of disease is really complicated and really difficult. For one, it poses a great diagnostic challenge. I think as we described, the facial dysmorphology is very subtle. I think it's very difficult, especially for the general practitioner, to say, okay, I'm worried about this patient's face. I need to refer them for a fetal alcohol syndrome referral. And really, it's a place that's best managed by specialists. At the same time, we're the ones probably seeing most of these kiddos, and we're probably just missing this diagnosis just based on how difficult it is to make the diagnosis. In addition to the diagnostic challenge, I think there's a difficulty based on the stigma of alcohol consumption during pregnancy. I think if my kid were to be diagnosed with fetal alcohol syndrome, I think it would be very hard for me to go to the pediatrician. Every time you go to the pediatrician, you get reminded that a decision you made during pregnancy may or may not have caused problems to your kiddo. And I think that would be something that's really hard to tolerate. And I think that fear really drives women from fearing disclosing prenatal alcohol use based on this great stigma. And I think both these things combined really make it a diagnostic challenge to understand the true prevalence of fetal alcohol syndrome. But the approach they took in this paper was that they took this active case ascertainment approach where they take experts in fetal alcohol syndrome, go out into these 4 different communities, and just pan screen across all first graders in that community. And this is opposed to a passive approach like chart review, where we're relying on physicians to make this diagnosis. Really here, we're taking experts into a community and trying to figure out the real prevalence of this disease. And what they found for the prevalence full fetal alcohol syndrome, anywhere from 0 to 0.7%. And on the spectrum of fetal alcohol spectrum disorder, they found 1 to 5% of all kids, all first graders in these 4 communities had fetal alcohol spectrum disorder. This sounds pretty high. At the same time, just to go back to this data I showed you before, this is the data from the CDC about how many women drink during pregnancy. And again, in the black bars, I'm showing you binge drinking over time from 1991 up to 2017. And we see that roughly, 1 to 4% of pregnant women are binge drinking. Binge drinking is the form of alcohol consumption that's the most closely linked with fetal alcohol syndrome. And if you consider that 1 to 4% of women binge drink, it's not completely surprising that fetal alcohol spectrum disorder would have a prevalence of that same number, 1 to 5%. And just to put that number, 1 to 5% in perspective, if you take the lower limit of that 95% confidence interval of 1%, here I have the prevalence of fetal alcohol syndrome, 1%. This is the prevalence of the 3 other important causes of intellectual disability. And you can see that even on the lower limit of this prevalence of 1%, fetal alcohol spectrum disorder would outpace all other forms of intellectual disability combined. The important thing to note here is that we don't have a cure for autism, we don't have a cure for Down syndrome, we don't have a cure for Fragile X. But fetal alcohol spectrum disorder, this disease is 100% preventable. We don't have a cure for it per se, which is to say that once a patient is born with fetal alcohol syndrome, we cannot do anything to reverse it. But this is something that's entirely preventable, which raises the question of if we can prevent this, do we have the potential to make a huge difference in the lives of kids and the morbidity of intellectual disability? Just to bring back the relevance here to South Dakota, this was a paper from last year from Dr. May from the same group that did the last paper. And this was a project where they focused on the same question in a Midwestern city. And I'm not sure if I'm allowed to say what city this is, but this is a city in the Midwest, has a population of 170,000, is majority white, it's majority Christian, and it has roughly average to above average levels of heavy drinking. And I just want to make the point that this is a set of demographics that applies widely to cities in the Midwest, including our city here. And what they found is the prevalence in this city was that the full fetal alcohol syndrome, 0.3%. And then for the spectrum of fetal alcohol spectrum disorder, they found 1 to 4%, really similar to the US-wide population that they had reported previously, suggesting that the US-wide prevalence and this city prevalence really are in line, and that this 1 to 4 or 1 to 5% prevalence of this disease could actually be a truer answer of how prevalent this disease is. So that wraps up the second part, how common this disease. And in this first 2 parts, I really tried to focus on the research and the data and the numbers of fetal alcohol syndrome. In this last part, I'm kind of just going to give you my opinion, my thoughts about family medicine and fetal alcohol spectrum disorder. So the question is, why does family medicine matter to this diagnosis? And to me, one of the things that made me quite interested in this disease is that fetal alcohol spectrum disorder, this is something that affects the whole family. So you have the patient, you have the index patient with fetal alcohol spectrum disorder, and obviously that patient is affected. That patient may have intellectual disability, anatomical abnormalities, problems that are going to stick with them potentially for their whole life. In addition to that, we potentially have alcohol use disorder in the mother. In addition to that, we have the stress that comes along with raising a child with intellectual disability, could maybe be unmasking underlying psychiatric disease in the parents, potentially something like a bipolar disorder, potentially leaving less parenting to be done for siblings, causing the unmasking of diseases like ADHD. And really, while this one patient has the disease, really everyone across the board is affected, and it can really have a significant impact on the whole family. And this, to me, when I was thinking about what residency I wanted to apply for back in medical school, I really became impressed with the idea that in family medicine, we have the opportunity and the privilege to take care of the whole family. I think that's something I continue to really value now as a resident and having my, just a little bit of clinical experience, but it's been really rewarding to me to have the opportunity to take care of entire families. And some of the things I'll talk about briefly are just how can we contribute to this diagnosis, how can we help, and finally, why should we help? First thing is, how can we diagnose this syndrome in kids? So really the facial dysmorphology, I think this is very difficult. I think these findings, again, like I said, are very subtle. I think this is something where we really have to rely on our consultants, on the multidisciplinary clinics, where they have expert dysmorphologists who have seen hundreds of kids with faces like this and who can really give us a true understanding of whether a kid's face is consistent with fetal alcohol syndrome. The second thing regarding this diagnosis with kids is neurodevelopment. And I think certainly if there was like a 3-year-old that wasn't walking, wasn't talking, I think I could tell you that that kid is neurodevelopmentally affected. But if you were to ask me which kids are 1.5 standard deviations below the mean for neurodevelopment, I think I would have no idea what to tell you. And I think something like neurodevelopment is even something that's best left up to the specialist to determine exactly the degree of neurodevelopmental defects. I will say one area where I think we as general practitioners and family medicine docs can contribute to this diagnosis in kids is growth retardation. Certainly, we see lots of kids with poor growth, and fetal alcohol syndrome is probably not going to be number one on the differential diagnosis. At the same time, the differential diagnosis for this presenting symptom is vast. And I think it's just important to keep fetal alcohol spectrum disorder on the list of differentials when we see a kiddo with poor growth. And to me, really, the high yield part of family medicine in making this diagnosis comes with our interactions with the mom. I think we have a great opportunity to diagnose prenatal alcohol use in the moms. And to me, this really has to do with our opportunity as family medicine providers to have a relationship with patients. Where perhaps we took care of the mom when they were a kid. Perhaps we take care of the mom's other kids. Perhaps we take care of the mom's parents. Perhaps we've been a part of a community for a long time and we have outside of a clinic relationship with the patient. I think there's all sorts of ways that we as family medicine providers have an opportunity to have a relationship with the patient. And I think this really helps as far as the stigma regarding prenatal alcohol use. I think for a patient to admit to prenatal alcohol use, I think you have to have a level of comfort with the provider to feel that they're not going to shame you, that they're not going to make you feel like a morally deficient person because you drank during pregnancy. This was just one thing I saw in the literature of approach to this question is asking when was your last drink? And this is something that's especially well suited to a first prenatal visit. Perhaps a pregnant patient presents to you at 7 weeks, had been taking the positive pregnancy test, and they said they last drank 2 weeks ago. But at that time, they did not know they were pregnant, so the stigma is much less. There's much less guilt involved in drinking during pregnancy in that interval when they're not aware of pregnancy. At the same time, that's also a time when the alcohol may have a big effect on embryologic development and may be a time that's important to this fetal alcohol spectrum disorder, so something that's important to know for clinicians. And just one last side note, I just want to talk about the stigma of drinking during pregnancy. I think over 200 years ago, the first time an American physician described addiction as a disease regarding this loss of control. And this understanding at that time really corresponds with the modern day view predominantly held by neuroscientists that addiction is a dysregulation of the brain reward system and the feedback loops in the brain. And still, despite having this conversation for the past 200 years, I think there's still a lot of stigma that surrounds addiction. I think people who drink alcohol during pregnancy, I think people who use meth, people who use heroin, I think they are made to feel like their decisions are poor moral decisions, that they have to stay in the dark, that they have to stay in the closet regarding this decision, and that makes it very hard for them to seek medical care. And I think this stigma is particularly intense with drinking during pregnancy. I think certainly it's there with drugs, but I can't tell you how many pregnant patients that I've seen that will tell me that they've used meth and will absolutely say vehemently that they have not drank alcohol during pregnancy. And I think we have to ask ourselves, is this stigma justified? I think initially the people who kind of created the social stigma regarding drinking during pregnancy, I think it was well-intentioned. I don't think they meant to make anyone feel bad. I think they were truly looking out for the well-being of kids. At the same time, alcohol is legal. You know, we're not talking about illicit drugs. This is something that women can go out and do anytime they want. And I think the second question we have to ask is, a lot of alcohol is bad, that's for sure. The research is consistent, but it's not quite as clear that a little alcohol is bad. And the question is whether we should be making such an intense stigma around this decision of drinking during pregnancy if the science really is not necessarily there to be a slam dunk to say small amounts of alcohol are bad during pregnancy. And these are two questions that I kind of left thinking about often. This first question I've already talked about a little bit, so I won't touch on it too much, but to what extent should we as healthcare providers limit a woman's decisions during pregnancy? And the second question I have is, has this stigma, have we, by creating this social stigma around drinking during pregnancy, have we actually made the diagnosis of fetal alcohol syndrome worse? We've made it harder for women who maybe casually drink alcohol during pregnancy. We've made it harder for them to disclose alcohol during pregnancy. I think that stigma goes 100-fold for women who are binge drinking a case of beer a day, who are drinking a handle of vodka a day. I think we've made it hard for these patients to seek prenatal care. I think we made it hard for them to also seek addiction care. And this is really consistent with the literature that said the moms of patients with FASD, these are predominantly moms who had little to no prenatal care. And finally, how can we help? I think regarding the kids, the best things we can do are refer to multidisciplinary clinics. And I think we have to rely heavily on our colleagues in speech pathology, our colleagues in occupational therapy, physical therapy, teachers in the schools, counselors, parents. I think largely as clinicians, we do not have a ton to offer these kiddos, but I think by referring them for these early interventions, like in South Dakota, birth to 3, I think these kids can really have some benefit. But to me, my thought is, how can we help these kids? I think we can help these kids by supporting the caregivers. I think we can help these kids by helping the mom. I think we need to be cognizant of the opportunity we have of pregnancy. This is really a high motivation time. This is a time when moms and dads are very, very motivated to work on their health, especially to stop their drug use habits, their alcohol habits, their smoking habits. And I think this is a unique opportunity we have in the lifetime of a patient to interject some healthcare interventions. For instance, treatments for alcohol use disorder, which can range from pharmacologics to counseling to peer support groups like AA. We can also, a lot of the times, these patients will have comorbid psychiatric conditions like anxiety and depression, and these are some things that can be easily managed by a primary care practitioner. And I think something that probably doesn't come up enough is medical care for dad. Certainly, a lot of times, these FASD patients will be in single-family homes with just the mom. At the same time, if the mom's coming in and there's a dad in the picture, they can be encouraged to come in if they have alcohol use problems, if they have comorbid psychiatric conditions that need to be dealt with. So that's what I have for my talk. So just to summarize, throughout history, alcohol during pregnancy has been controversial and people have been asking questions about it probably since the beginning of time, but at least for the last couple hundred years. In regards to the epidemiology of FASD, anywhere from 1% to 5% based on the most recent studies. This would make it the most common intellectual disability. And in addition to this, this is a completely preventable disease, suggesting that by intervening on this diagnosis, we could have significant benefits to the morbidity of intellectual disability. And then I think the last point I want to make is that to help FASD patients, we obviously need to support the kids. I think it's intuitive and I think obvious that everyone would want to help the kids who are innocent victims. They made no decision on their part to be exposed to alcohol during pregnancy, and I think it's very obvious that everyone would want to help these kids. At the same time, I think it's important to keep mom and dad in the picture. Certainly, it can be hard because they perhaps made decisions that led to this diagnosis of FASD. At the same time, I think the best things we can do for these families, the best things we can do for these kiddos is to make sure we can put the mom and dad in a position to take care of their kids so we can empower them to create a good family structure for their kids. And that's what I have. At the end of a talk at CFM, at Center for Family Medicine, we're supposed to show pictures of our family. This is a picture of me with my son. We're thinking about something. This is my daughter being fierce. This is my son loving school, apparently. And this is my wife, Katie, who is a constant source of inspiration to me to make the world a better place for moms. So thank you again for tuning in. If you have any questions, I think you can put them in the chat. Otherwise, I'm happy to talk about this. And thank you again for your time.